Okay, so talking about separation anxiety disorder. So separation anxiety disorder is defined as excessive anxiety that occurs when a child is either separated from the home or significant attachment figures. These kids also have a lot of trouble with anxiety about losing that person or that caregiver or significant attachment figure dying or something bad happening to that person. So such anxiety is actually normal around the age of 2. It's part of normal development. However, if the symptoms start later in childhood or last for a longer period of time than they should, and they begin to, of course, impair function, then we diagnose these kids or children with a disorder. The symptoms have to last for at least 4 weeks, so symptoms must be present for at least 4 weeks, and the onset is before the age of 18. So the bottom line here is the things you want to remember is, again, excessive anxiety or worry about being separated from the house or being separated from the significant attachment figures or caregivers. And then we want to know that these symptoms have to last for at least 4 weeks and that the onset must be before the age of 18. The prevalence is actually kind of high. Prevalence is 4% in school-age children and 1% in adolescents. So as children age, they kind of grow out of this separation anxiety. However, we still see about 1% of adolescents suffering with it, and it occurs equally in boys and girls. Treatment for these kids is generally cognitive behavioral therapy, SSRIs, and buspirone, which is an anxiety medication as well, usually indicated for generalized anxiety disorder. What we see here, though, overall, is that the key points that you want to remember is what's the definition, and you're going to look for that kind of stuff in the vignette, that the kid is afraid to go to school, doesn't want to leave the house, doesn't want to leave the parent, and it's affecting their ability to do things, go to school, etc. It's impairing their ability to function, essentially. It has to be present for at least 4 weeks, has to be present before the age of 18, or the onset must be before the age of 18, and it's about 4% of school-age children, 1% of adolescents. Treat them with things like therapy, cognitive behavioral therapy, and SSRIs, and buspirone. Selective mutism. So selective mutism, the children with this disorder will not speak in specific social situations, even though their speech is fluent in other settings. So essentially, with selective mutism, the child is able to speak fine in certain situations, but in others they're unable to, specifically social situations. The child will communicate non-verbally during those times, so they'll maybe gesture with their eyes, they'll gesture with their hands or head, etc. But they will not communicate verbally, and they won't speak. So the symptoms must be present for at least 1 month. So again, 4 weeks, 1 month, and the child should be comfortable with spoken language. So the other key point there is you don't want to diagnose this in someone who, say, is an immigrant to this country and doesn't speak the language or doesn't have a proper grasp of the English language, let's say. Those people would not be selectively mute. They just might be uncomfortable speaking because they don't fully understand the language at this point. So that's one of the situations that you might want to hash out before giving this diagnosis. The disorder is uncommon and occurs in less than 1% of children, so not really very common. And for these kids, it's usually treatment CBT or cognitive behavioral therapy, psychotherapy, and SSRIs. So they just don't speak in certain situations. And I'll finish up with the elimination disorders here because I think I have enough time to cover them. So elimination disorders are also kind of important, and they tend to be pretty testable points. So encopresis is repeated passage of feces into inappropriate spaces. It could be intentional or involuntary, and it's not due to a medical condition. The behavior occurs at least once per month for 3 months. Primary, and you can define it as primary or secondary. So primary encopresis would be that they were never toilet trained to begin with, and secondary would be that they regressed after toilet training. So secondary, they had achieved continence and then lose it, or vice versa for primary. So the child must be at least 4 years old, and the prevalence is approximately 1% of 5-year-olds, and it's more common in boys. So you would say by 5, most kids should be able to hold their both urine and feces and not have issues with encopresis or enuresis. So what I would remember from here is that it's divided into primary and secondary. Primary, they never achieved they were never toilet trained. Secondary, they regressed after toilet training. You want to remember that the child must be at least 4 years old. and you want to remember the prevalence is 1% of 5-year-olds. So those are kind of the big things, and it occurs at least once per month for 3 months. So once per month for 3 months is also important. The last elimination disorder, probably the more important of the two, is enuresis, which is manifested by repeated voiding of urine into the bed or clothes. It can be intentional or involuntary, and it is not due to a medical condition. So, of course, the first thing you want to do on one of these kids is get a UA, see if they have a UTI or something like that, figure out if there's something else going on besides just enuresis. Before you make this diagnosis, you want to rule out all the medical stuff. It occurs at least twice a week for 3 consecutive months. So it occurs at least twice each week for 3 consecutive months. That's the key point. You want to remember the timelines. Those tend to be the very testable points on any of these disorders, is the timeline. So remember, it occurs at least twice each week for 3 consecutive months, and it causes significant distress, social impairment. Again, primary and secondary. Primary, the child was never toilet trained. Secondary, the child was toilet trained and regressed. The child must be, in this case, at least 5 years old, and the prevalence varies with age, of course, from 7% of 5-year-old boys and 3% of 5-year-old girls, so again, more common in boys than girls, to 1% of 18-year-old boys and less than 1% of 18-year-old girls. So by 18, most of these kids don't have this problem, but before the age of 18, there's pretty high rates for 5-year-old boys and 5-year-old girls. Treatment, the best way to start and the most effective long-term treatment is to do behavioral therapy techniques, which include star charts and bell pad technique. The common answer is usually the bell pad techniques. So that's where a pad is placed on the bed. When it becomes wet, a bell sounds, and this starts to help the child to become successful in recognizing when they're wetting the bed, and helps them to then change that behavior over time. If that's not successful, you can go to pharmacotherapy or medication, and this would be the next step. There's 2 medications, imipramine and vasopressin, which have both been shown to be effective. The issue with the medication is children tend to have relapses after stopping the medication. So it's far better to do something like the bell and pad techniques or the star chart, because that's going to have longer term implications. If you go right to pharmacotherapy, they're likely to have relapses after stopping the pharmacotherapy. So enuresis can also remit spontaneously, so you're not going to want to continue the medications indefinitely at that point, because there's obviously no reason to. So basically, behavioral techniques first, pharmacotherapy second. Pretty common. Children should be able to achieve proper continence by the age of 5. So, and the timeline here, you want to remember at least twice each week for 3 consecutive months. And that covers all of pretty much the child adolescent stuff that I'm going to talk about for now. There will be additional topics in the future, but this is basically, your board exam, board prep kind of stuff that you're going to want to know for testing purposes.